Last, but certainly not least today is Dr. Glenn Smith, who for many years was at the Mayo Clinic in Rochester, one of the pioneers of the diagnosis of MCI, and at the same time really recognized the need to look into interventions. And so is now at the University of Florida and is going to tell us about some of the multi-component interventions that he and his colleagues have really spearheaded. So thanks so much for being here.
Thank you, Ben. It's a privilege, and boy, I'm honored to be with amongst this group. Some really amazing talks today. I draw a couple interesting paradoxes or similarities. The first is that while Dr. Stringer is retired and doesn't appear to be so, I'm not retired, but people often are confused that maybe I am. And then the second similarity, only more intense, is that, well, Alex realized he was standing between you and lunch. I'm standing between you and happy hour, which is an even more perhaps risky position to be in. But I want to talk a little bit about multi-component interventions, and I highlighted in mild cognitive impairment here because I think some of the materials may have suggested I'd be more broadly focused, but I'm really limiting my my discussions today to MCI. And first I have to gain mastery of, where do I point this to get it to move? I'll just do it that way. So a few disclosures in terms of funding and funding sources, and also I receive probably even smaller royalties than Tony does from the books that we've developed on MCI and dementia. And you'll learn about me today that I'm simple-minded, so I have to always try and keep things simple. But I always try and ground myself in what we're trying to accomplish here. And this is a slide that we routinely present to the people that are engaging in our intervention programs. And it sort of contextualizes that, first of all, we're all going to die. Second of all, that Alzheimer's disease and dementia are diseases of people who've lived past median life expectancy. So we do have this notion or this concept we talk about, compression of morbidity. And I think in many respects, when we're engaging in interventions with MCI, and I think, Tony, you alluded to this point, for a lot of years, we didn't believe in intervening in dementia because we knew people were going to decline, right? We knew stroke people could get better. We knew TBI people could get better. We knew that Alzheimer's patients were going to get worse. So we had to make this shift to understanding we're trying to compress morbidity. So, you know, these are just heuristics, but what really scares us about Alzheimer's is this notion of rapid loss of functional ability till you become disabled, and then this long period of disablement. And some of our interventions, like say the cholinesterase inhibitors, initially they seemed to delay, but we didn't know that they actually led to less time in disablement. And so a simple delay model isn't necessarily adequate, because if you live longer and say have the same amount of disablement, have you really accomplished anything? So what we've long articulated is this notion of trying to shift that curve so it looks more like the ideal, because I think most of us would agree, I want to function, you know, at the same level I did when I was 29 years old until the day I step in front of that truck. And so I have no period of disablement. Anything we do to move things more towards the blue line in our model is really a form of prevention. So what are the things we can do? What are the kinds of interventions that we can do? Well, we've heard a lot today about various forms of cognitively oriented treatments. We've heard some about various forms of education and planning, and I'll talk in a little bit about how paradoxically we used some psychoeducational programs as active control, only to find out they had more benefit than some of our other programs. We can do mood management. Of course, physical exercise is something we haven't talked about today, but in terms of you think about that list of what do people recommend after they've seen their doctor, almost everyone recommends get more physically active, right? The whole mantra out there, what's good for the heart is good for the brain, is predominant now. And so various other interventions. Now, as Professor Hempstead alluded to, much of the 90s, we were engaged in developing this concept of MCI. How do we best characterize it? Does it really help us? And one of the real legitimate criticisms at that time was, why diagnose early if there's nothing to offer people? So I quickly got interested in, well, besides the medications that aren't existent then or weren't particularly helpful then, what else can we do? But at almost the same time, we got approached because I had been publicly sort of critical of computerized cognitive training in a couple places. And so the people behind a program that was at that time called Brain Fitness, subsequently became Brain HQ, invited myself and Liz Zielinski to design an independent RCT of that particular product, Brain HQ. And so here were the results of that study. We tried to design it with a sort of a transfer hierarchy in the trial, so that we see in the lower left that we had a pretty good idea. Computerized cognitive training of speed would improve processing speed. What would it also transfer to other kind of traditional neuropsych measures? And then lastly, would it transfer to patient self-report regarding memory problems in daily life? And in this series of reports that we produced, we did see some modest effects on certainly on processing speed that persisted well after treatment to 3 months out. We also saw some benefit on a composite we called overall memory, but frankly, it was working memory measures. Not so much on actual memory function, but also some benefit in patient-reported outcomes. So, but also at that time, I was working with a fellow named Melanie Greenaway, now Melanie Chandler, and we were trying to rip off from our traumatic brain injury model systems program this calendar training and apply it in MCI. And so Melanie did this nice development of how we could develop a curriculum to fit folks with MCI and train them up in this calendaring system that Solberg and Mateer had originally developed for TBI. And just one quick point about this that kind of takes a little bit of exception with Dr. Hamstead's distinction between rehearsal-based strategies and external aids. The one key thing we had learned from the TBI model system is that you can't hand people an external aid. If you don't train them in it, if you don't teach them to use it, if you don't do massive rehearsal of it, it doesn't take. There's no real development of it. So I think I tell my graduate students all the time when they go home and keep a calendar and write things down, I say, you just told this person they have a memory problem. Now you're asking them to remember to do these things. It doesn't make too much sense. You've got to train these things. So we started then asking ourselves in MCI, which was better, right? Were you better off to use kind of a restitution strategy, a training strategy, or were you better off to use a compensatory strategy? And interestingly, somewhere around this time that Melanie had written this R01 and we were doing this research, my father was diagnosed with pancreatic cancer. And so I knew in that moment how my father was going to die. We took him to see the cancer specialist, and I was expecting to hear whether we should do surgery or whether we should do radiation or whether we should do chemo. And what did they say? We're going to do surgery, then radiation, then chemo. You don't have to choose. You have a terminal illness that's going to degrade your quality of life and going to cause your death. And we can't avoid that, but we can do everything we can to maintain your optimal functioning for as long as you can. And the epiphany to me was, what is Alzheimer's disease? It's a terminal illness that's going to degrade your quality of life, and we should do everything we can to sustain the highest, best outcomes for you. So we stopped kind of trying to compare and started saying to ourselves, what's everything we can do? And we went back to that list, and that led a team of us at Mayo to develop the habit program. So this is truly, the kitchen sink. This is a 50-hour program. It's 5 interventions delivered 1 hour each in each daily session over 10 days. Now we've played with the schedule. We've had a 6-week version of this. We've had a 2-week version of this. You can't get it more compact than 2 weeks, really. And some of us are now running a 3-week version, but it has each of these components. So it has that memory compensation training, the memory support system. It has that brain fitness or brain HQ component. We already had a curriculum in our Alzheimer's Disease Research Center to teach about what is MCI, what is dementia, what medications can you avoid, how do you optimize your sleep, yada, yada, yada. We brought that into it. And we wanted to figure out how to do physical exercise. So we did some early iterations where we did walking. But in Minnesota, in the winter, not a great intervention. We did resistance training, but then we had to limit ourselves to certain facilities that had really good gyms. Finally, we hit upon yoga, because if we wanted to, we could do a yoga session right here, right now in your chairs. And it wouldn't matter whether you were a marathon runner or in a wheelchair. We could find the right adaptation of yoga to give you enough increase in your heart rate and your respiration to call it aerobic. So we built that in, and then we're already running support groups for carers of folks with dementia and MCI, but we added a specific group for the people with MCI who we call in the program participants, partners and participants. Now, I think that kind of presages a lot of the developments that have happened since in terms of multi-component treatments, although not all of these have been specific to MCI, right? And perhaps, the one that seems most well known to me is the Finnish trial, the finger study, where they showed an intervention targeting exercise, diet, some aspects of cognitive training could have positive benefits in people at risk for Alzheimer's disease. They weren't formally diagnosed with MCI. And then that led to the US Pointer trial, which is an American spinoff of Finger that's been funded by the Alzheimer's Association and others. Someone earlier talked about MAPT in France, and there's been SMART in Australia, and I won't even try and pronounce the name of the Japanese trial. But recently, as part of her qualifying exam, my student, Lana Ying, decided to do a systematic review of all the multi-component trials that have happened since an earlier systematic review that Dr. Chandler and I and others did. And so you can get the slides busy and illegible, but what I really want you to see is just how many people are throwing what kinds of kitchen sink approaches at these populations. So I averaged these, and I think it's 4.4 interventions per study in these multi-component interventions. And there's aerobic training, there's balance training, there's physical activity promotion, and then a group of cognitive training and some of the other categories we've talked about. So these multi-component studies have really kind of become more in vogue of late. I want to just pivot for one section to think about not only the kind of plethora of different interventions we can consider, but also how we think about our cognitive portfolio of outcome measures, not just cognitive, forgive me, but outcome measures. So in our habit program, from the get-go, we had all these clinical measures, and we sort of began to design our studies using these clinical measures. So we would ask patients about their quality of life, about their level of depressive symptoms and anxiety symptoms, about their self-efficacy. We would measure global cognitive function on the dementia rating scale, collect the functional assessment questionnaire, and Sarah Farias's ECOG, memory-specific daily functions questionnaire, from the partners, and then ask the partners about themselves. So eventually we did an exploratory factor analysis and then a subsequent confirmatory factor analysis, and found that, there's a lot of shared variance here. And we're really talking about three things. Remember, I said I need simplification. We're talking about level of impairment or severity, cognitively and functionally. We're talking about the diagnosed person's level of adjustment, and we're talking about the partner's level of adjustment. And so we can create these aggregate measures or composites or not, but I think it really is important that we distinguish and consider all three of those areas when we think about intervening in clinically meaningful ways in this population. So one danger of aggregating too much is that we may miss some of the important relationships between the measures within a given domain. So both self-efficacy and quality of life would be considered measures in the participant adjustment domain. But here we see in a mediation model that we need to consider how they relate to each other, that possibly, as we were talking somewhat earlier yesterday, that interventions may lead to certain outcomes by way of these mediators. And I think this one about self-efficacy is really important across the board, that maybe anything we do, whether it's get people feeling more physically healthy or more flexible through yoga, that benefit in self-efficacy that they derive from that may translate into better reports of quality of life and so on and so forth. But we took this 5-component intervention and we had the opportunity to study it in a unique kind of setting or funding mechanism, because we submitted a proposal to PCORI, which, if you've never heard of PCORI, it's something that was created by the Affordable Care Act to study issues of great importance to patients. And so almost all of their studies have to have a comparative effectiveness design, because patients don't just want to know, does it work, but how does it work relative to my other choices, right? So a comparative effectiveness trial in selective serotonin reuptake inhibitors wouldn't compare the next gen to placebo, they'd compare it to all the existing. So we tried to operationalize our comparative effectiveness trial of the different components in habit in this comparative model by using a regrettable now, but I think intriguing design, where I don't know if I emphasize this. This is a group-based intervention. So we didn't randomize people, we randomized sessions. So in each session, every group got the same thing, because it would have been completely impossible, frankly, to mask if we had different people getting different components. So in the trial, what would happen is we would randomly assign a session to leave one thing out. So you get 4 things, but you'd miss 1. And then the next section, there was block randomization. So eventually, every one of these components got left out of at least one session. And then to understand the data, what we had to say is, what did it cost you to miss that in terms of our outcome measures relative to the other groups? So if you take a measure like quality of life, I don't think most of us will be surprised about this. I'm going to try and master the laser pointer. I'm sure I won't. So, not surprisingly, you didn't lose anything if you skipped the computerized brain training in terms of reports of quality of life. There may actually be a slight improvement in quality of life for the people who didn't get brain training. But here's that benefit of wellness education, right? I'd always been taught that education alone does nothing, but perhaps education in combination with other interventions is really critical to motivating people to persist in those interventions or whatever the case may be. So here on self-efficacy, missing out on the yoga and missing out on the support groups was the most costly. And again, missing out on brain fitness, not so much. And in terms of the actual kind of patient impairment level findings, so you have here the clinical dementia rating scale, sum of boxes, and the functional assessment questionnaire. Here, missing out on yoga and missing out on computerized brain training produced the greatest costs relative to the other arms, suggesting those were two important interventions in the other arms that didn't have the same level of decline. And just a real emphasis, because I think we talked about this in our session yesterday and only kind of vaguely alluded it today. If we get into the space of dementia, Alzheimer's, mild cognitive impairment, then our models are generally not likely to be improvement models. So our study designs are complicated by the fact that no change is a treatment success, rather than improvement being a treatment success, on the presumption that over a sufficient amount of time, we will see decline. And we did here. And when we originally wrote this study, we were only going to follow people for 12 months. And our funder came back and said, our reviewers don't believe 12 months is long enough. We want you to take this out to 18 months, and sort of forced us to design. How often have you been told do a longer study? So it did mean, however, that we had to enroll fewer subjects, because for the same amount of money, fewer subjects. So we've tried to distill this now into kind of which outcomes seem most influenced by which interventions in this kind of comparative effectiveness trial. But again, I think the broader picture is that if we want to impact these three broad domains, we're probably going to need multi-component interventions, because none of us are surprised to hear different interventions accomplish different things. So we also had the partner outcomes. I won't belabor them here, but you see the same kind of thing. Now, before actually we ever finished this study, actually when we were rolling into the original randomizations, our funder also made us do the following. It made us ask people in this portfolio of outcomes, which ones matter to you the most, right? So these are ranked from 1 is most important to 13 or 12 is least important. And PT is the participant and PR is the partner. So the first thing I want to point out is that while I, prior to doing this research, was obsessed with function, because my model of dementia prevention is I may not be able to modify the disease and I may not be able to preserve cognition, but the difference between MCI and dementia, it's not cognition, it's daily function. So if our compensatory strategies can sustain function in spite of brain disease burden increasing, in spite of cognition declining, we've still engaged in dementia prevention in a compression of morbidity model. So it's interesting that right there in the middle is where both patients and partners ranked cognition. So neuropsychologists were obsessed with improving cognition. We asked the patients, maybe not as much. Now that may reflect to some extent that they've come to terms with their losses. That may actually be a positive adaptation on their part to say, I know my memory's crap. I can deal with that as long as I can still function and have a high quality of life. Interestingly also that we sort of saw the gift of the Magi effect a little bit in this data, that the patients were more concerned with partner outcomes. And of course, the partners were way more concerned with the patient outcomes. But by and large, these were the findings. We also asked them to rank the importance of the interventions themselves. All of the people doing these rankings had been through this program in its pilot phases. So even though yoga was really important, again, 1 is good, 5 is least good. They ranked the yoga least. They ranked the calendar training most, and they put our computerized cognitive training right next to the yoga. So what people valued doesn't necessarily track with what our findings tell us about what are the active ingredients and what's more superfluous. So now coming back around to where we are in a broader sense of what's the current state of the research in terms of multi-component. So this is, again, Lana's qualifying exam that will hopefully turn into a meta-analysis publication. So what she did is she organized these studies in terms of those 2 of those 3 broad dimensions. So impairment, she looked at studies focused on cognition and on daily function. And you can see kind of across the board, this looks a little bit like Alex's forest plots earlier. We've got a lot of studies where the confidence interval spans 0, and a lot of kind of small effect size studies, a few outliers, but presumably in a consolidated meta-analysis, we're going to see kind of a modest but positive effect on patient impairment of these whole range of different multi-component trials. In terms of patient adjustment trials, clearly far fewer folks have looked at those. The effects may actually be a little bit larger than they are. The effect size is a little bit larger once we pool them for these kinds of studies. And I don't have a slide for partner adjustment studies because by and large, we neglect those outcomes in almost all of these trials. And just to reiterate Tony's point, I do want to say, we require partners in our studies. Many times it's the spouse, but not always. Sometimes we're going out there to try and we've actually used undergraduate RAs to serve as the partners when we couldn't find other people. But again, another paradox is probably the person living alone without support is the person who can most benefit from our programs. And yet, without a partner, our programs don't operate. So just kind of summing up here, this cognitively oriented treatments, really important issue, but just to kind of broaden our field of view, it's not the only treatment our interventions can focus on. And when we start asking our patients, it's maybe not even the most important treatment our interventions should focus on. Of course, different interventions impact different outcomes, and almost always with just modest interventions. But I would submit to you that cognitively oriented treatments might do well to be embedded in multi-component programs that include other components of exercise, wellness education, diet, or lifestyle modification. And I think we really need to work a little bit harder at incorporating patient preference in our components, although I'm going to show you some data in a minute that suggests there's not a one-to-one association between patient preference and how well they adhere to those. I just want to also emphasize the individual differences component of this. We talked about this absorption or penetrance a little bit earlier. So this is 3 hypothetical cases of people learning our calendar training. So 10 days to learn it. you move through 3 phases. The first phase, you just learn how it's organized. The second phase, you figure out how to use it for today. And the third phase, you start applying it to your real life. So person 1 never gets out of the first phase. Person 2 moves quickly to the third phase where they're applying it very well within 3 days of entering the program. And the other person is kind of a more typical. So there's huge individual differences in how well our training gets absorbed by people. And in this particular paper, Lise DeWitt, who's worked with both Roy and I, she tried to look at what predicted how well this people learned this, and discovered that it wasn't really their procedural learning, it wasn't really their working memory, it was just their declarative memory, is another way of saying how not severe were they in terms of their MCI that predicted this. And then, of course, as we all well know, the real bugaboo of our interventions is adherence. Not just can we teach people and get them to do it, but can we get them to continue to do it? And so this is some of our data across these 5 interventions, where we took a liberal approach to defining adherence. But what you can see on the far right side is people who aren't doing anything in that space. And so you can see kind of the differential rates of people at 12 months, whether they continue or don't. So, and these don't comport very well with what they said was the most helpful interventions to begin with. So just one last thought coming back to this slide and beginning to kind of think about it differently. It will be great if our interventions are disease modifying, but I'm not sure they will be. It will be great if our interventions can shift cognition, but even if they can't, I think we should still focus on what's our capacity to influence function, and then perhaps most importantly, even in people with functional loss, how do we give them the tools to be best adjusted to their losses? So I'll thank my team. I'm a minute over, so I'll stop. Thank you. Questions, comments, criticisms?
I noticed in the earlier review that you presented by one of the students, if you look at the multi-component interventions, the one thing that I didn't see there was the kind of work that Ben does with cognitive training combined with transcranial simulation. Is that something that you now consider to be a multi-component? I know we don't sort of think about those.
Well, I think so. Great point. And I'm interested also to pick up on this gentleman's point earlier about with these disease modifying treatments supposedly coming on the market, should we be looking at sort of those impacts as well? But just down the hall from me from my office that I rarely am in anymore is Adam Wood's office. And Adam Woods is a real kind of out there guy in terms of combining TDCS and Brain HQ here. So I think that I do believe those are multi-component studies. We didn't pull for that in this particular review. Maybe we should go back and do that. That's a very good suggestion, and it's important direction for the field. I think the preliminary results are very exciting.
Just very quickly, then, maybe you've shown it in a table with the map of the outcomes and the what sort of people felt was this important drop. But with cognition, I didn't quite see whether dropping the cognitive training element was worse for cognition.
Yeah, so one of the, again, another paradox. We got about 4 years into our research into all of this and realized we had no cognitive outcome measures. We were so focused on function that eventually in that comparative effectiveness trial at the 11th hour, we added a computerized cognitive assessment, and I'm blocking on the name of it now, but you'll know it well because it was developed in Australia. The CogState. So we have analyzed the data from Cogstate separately, but we didn't even include it in that factor analysis to see how well it loaded on the impairment variable. So the results have not been all that strong in terms of Cogstate. Yeah.
Because I think I would be surprised that the quality of life and mood maybe didn't seem to be at a big loss if we drop cognitive training.
Mhm.
Expected that cognition.
Yes.
Correct target.
Yeah. Yeah. I'll send you a paper on that because we have published on it, and you're right. That was the one intervention where there seemed to be a signal. One other thing I kind of just want to mention about comparative effectiveness designs is I think we should expect more modest effect sizes in those designs because everyone's getting something, right? So there are certainly have to be some kinds of non-specific effects that boost everybody, and then you're trying to see a signal above and beyond. So yeah. Was there another question? Yes.
First, great study, great talk.
Thank you.
I'd like to hear more about your views on self-efficacy, how important is as if we can say a psychological mechanism of intervention, and if there's other ways that we can explore psychological mechanisms. And I think what really influences self-efficacy, if there's other constructs like personality traits or other measures like mood that are related. So I'd like to
Yeah.
more about this.
I want to amplify something that I heard Sylvia say this past couple of days, which is one of the areas where we think we see the biggest boost in self-efficacy is for the people who figure out how to do Brain HQ, because they're older adults, they're using a tablet, they're logging in, they're managing to interact with it, and at least anecdotally, learning to write stuff in my calendar. I've always written stuff. Although one reflection on that, if you'll allow me, we were talking about older adults and interacting with technologies. I'm a real believer in this concept of retrogression. That is, Alzheimer's disease progresses, last learned, first lost. First learned, last lost. So whenever we have people pushing us, and they do, why can't I just do this on my cell phone? We say, you can now, but I'm worried about when you really need this tool. When you start forgetting so bad that you don't know what to do without your calendar, you may also be forgetting so bad that you don't remember how to log into your cell phone. So we really push people to the thing that they've done for 50 or 60 or 70 years, as opposed to when did the iPhone come on the market? 2005, right? So for some of you, you've not known life without it. But for our current cohorts of older adults, it's still pretty brand new. So, but self-efficacy, I think we see that benefit in things that are especially novel that they master, like yoga, and I do believe it creates this general favorable disposition that causes them to say their quality of life's better, their mood's better, because there is a lot of shared variance between these kinds of how are you doing kinds of measures. Did that answer your question or not? Okay.